Leukemia, acute leukemia, chronic myelogenous leukemia, the leukostasis reaction, which is sledging, myelodysplastic syndromes want to become acute leukemia, chronic lymphocytic leukemia doesn't get treated in the majority of cases, and hairy cell leukemia. For acute leukemia, you can look for a history of myelodysplasia and signs of pancytopenia such as fatigue, infection, and bleeding. Now, the signs of infection happen even if the white cell count is normal or even increased, and that's because infection is a common presentation because leukemic cells, blasts, just don't function normally. The white cell count can be up, down, or normal, but they always present as if the white count is low because blasts are malfunctional. The most frequently tested acute leukemia is M3, which is also known as acute promyelocytic leukemia. This is because M3 is associated with disseminated intravascular coagulation, because M3 gives you DIC, M3 DIC, because there's no distinct clinical presentation between the three subtypes of ALL. There's no distinct presentation between M456. That's why they are always asking about M3, because it's the only one that has a distinct clinical presentation, because the only one that makes you bleed. None of the others have a distinct presentation, so you can't construct a question about things that are all the same. This is the only one that's different and unique. The best initial test of acute leukemia is the blood smear, because on the blood smear you see blasts. Blasts are never a normal variant, ever. Blasts are never to be considered a normal variant. People don't harbor asymptomatically blasts. The most accurate test is to sort out the cells to see what you've got in there with flow cytometry. Cell sorting. It distinguishes between the different subtypes of acute leukemia. It distinguishes the specific CD subtypes with each type of leukemia. Older tests like myeloperoxidase, they're characteristic of acute myelogenous leukemia, but it's not as specific as sorting it by cell surface subtype, like CD receptors. The Auer rod is an eosinophilic inclusion body characteristic exclusively of acute myelocytic leukemia. It is most often in the APL. Now, this Auer rod, although it may not be as useful as flow cytometry, is a very common question on step 2. Both forms of acute leukemia, AML and ALL, are treated initially with chemotherapy. The goal of this is to go into remission. Well, what does remission mean? It means you remove blasts from the peripheral blood smear. That's what inducing a remission is. Now, when you induce a remission, the question is, are you going to stay in remission? See, we don't know for sure whether chemotherapy alone will keep the leukemia away or whether it'll come back. Ultimately, only 30 to 40% of patients with acute leukemia are controlled just with chemotherapy. So the question is, should you proceed to bone marrow transplant after remission or just continue with more chemotherapy? Now, the reason why this is important is that bone marrow transplant is an extremely dangerous procedure. Even in a healthy person, it will kill 10 to 15%. In an older person above 40, 50, 55 years old, it can have a mortality of 20 and 30%. So would you subject yourself to a bone marrow transplant if you went into acute remission? If you went into remission, would you go for bone marrow transplant or wait for more chemo? The answer to that is if your prognosis is poor. In other words, hey man, you're going to recur. It's going to come back. You should go straight to bone marrow transplant. If your prognosis is good, meaning, oh, you're not going to come back, yours isn't going to come back, you got a 95% chance it's going to stay in remission, well, then just keep chemotherapy. Now, you might say, why not just wait for it to relapse? Well, there's a very good reason for that. Relapsing acute leukemia is extremely difficult to control. It's very hard to beat it back under control. So that's why once you get it into remission, you've got to decide. And how do you decide? The answer is cytogenetics. That's why the answer to the question, which of the following is the best indicator of prognosis in acute leukemia, is cytogenetics. Cytogenetics, kind of like an individual assessment of chromosomal characteristics found in each patient. In a way, it's like a fingerprint of your own individual characteristics. In other words, you could have 3 people with acute myelogenous leukemia. One might have chromosomal abnormalities that indicate a 5% chance of recurrence, another 50, another 70%. That's why you use cytogenetics to say, hey, good cytogenetics, less chance of relapse, just give more chemotherapy. Oh, I'm sorry, sir. Your genetic testing shows that you have a very high chance of your cancer recurring. I think we really need to transplant you right now. When is all trans retinoic acid atro the answer? It is for M3, acute promyelocytic leukemia. Atra is basically a derivative of the same stuff we use for acne. Cis-retinoic acid is what we use on top of pimples, on acne. Trans-retinoic acid takes, and this is a miracle, it takes promyelocytic leukemia, which is the most fatal form of cancer in all of humanity. It is a disease where 90% of people are dead within 6 weeks, and transform it into the most curable form of leukemia. It's amazing. M3 promyelocytic leukemia is a disorder that if you don't treat them on the first day you meet them, once the diagnosis is made, people start to bleed to death on the very first day. You've got to treat them immediately. The other question is about intrathecal chemotherapy, such as methotrexate in acute lymphocytic leukemia, ALL patients, acute lymphocytic leukemia. It prevents the relapse of ALL in the central nervous system. This is superior to using cranial radiation. It's superior to radiating the spine and the brain because the radiation of the spine and the brain results in growth abnormalities. Now you've got to sterilize the CSF of leukemia or it will recur there. The most tested facts for acute leukemia are M3 promyelocytic leukemia gives DIC, M3 DIC, all trans-retinoic acid for M3 and Araras and AML, and intrathecal methotrexate for ALL. Next disorder is chronic myelogenous leukemia, CML. CML presents with a high white cell count that's all neutrophils, and those neutrophils look normal on a smear. There are no blasts on the smear in CML. The blood cells are part of acute leukemia, not chronic leukemia. Now, this is very important because there really is no single diagnostic characteristic on physical or history that will tell you it's CML. A big spleen or fatigue, night sweats, and fever are simply not specific enough to allow you to answer what's the most likely diagnosis as CML. It's rather vague. Big spleen is certainly not specific. Early satiety is because the spleen is right next to the stomach. It actually presses on the stomach, so a large spleen squishes your stomach so you feel full after eating just a little bit. Also, it gives you a sense of abdominal fullness and left upper quadrant pain because the splenic capsule stretches and is uncomfortable for patients. But all of these findings, including itchiness, pruritus, which is common after hot baths and shower, is simply not specific enough to allow you to answer a question to say, for sure, this is CML. Histamine is released from the basophils. So you look for a high white count and they're normal on smear. That's because it's like autism. You can't tell. You have to look at function. You can't tell by looking. There's no ultrastructural abnormality. When you have a person presenting with a high white count, it's very unusual for it to be CML. Not even 1% of high white counts in a hospital are CML. So how do you determine if it's a reaction to another infection, such as stress or leukemoid reaction or leukemia? CML rarely gives a small number of blasts and it should be under 5%. The basophils are increased, but that by itself is not sufficient. If the leukocyte alkaline phosphatase score, the LAP score, is a choice, then this is first. Leukemic cells don't have normal amounts of alkaline phosphatase. Alkaline phosphatase is a characteristic of normal cells. Normal cells have alkaline phosphatase, and therefore, if your white count is up as a reaction to another infection, you'll have a high alkaline phosphatase score. Now, leukemic cells don't have a normal amount of alkaline phosphatase score, and the LAP score is low in CML. If the LAP score is not a choice, or the question says, what is the most accurate test, then the answer is BCR-ABL. BCR-ABL can be done by PCR and peripheral blood. The BCR-ABL is the Philadelphia chromosome. The BCR-ABL is the right term for the 922 translocation. It is clearly superior to the LAP score because it is clearly the most accurate test of CML. Now, in the past, we used to have to do a BCR-ABL on the bone marrow. And that made LAP scores more useful because it determined who you would do a bone marrow on. But since we now have PCR and peripheral blood, if BCR-ABL is in the answer, that's the right test to do, BCR-ABL. The best initial therapy for CML is imatinib, the tyrosine kinase inhibitors. Imatinib, dasatinib, nilotinib, they're the best initial therapy. CML has the greatest likelihood, however, of all the myeloproliferative disorders to transform into acute leukemia, about 20% of the year. Imatinib and the tyrosine kinase inhibitors, stop that. They really do. They take a disorder, CML, that was almost 100% fatal at 5 years and make it almost 100% survivable at 5 years. Wow. So the question says initial therapy, it's imatinib, dasatinib, nilotinib. If the question says what cures it, only bone marrow transplant will cure CML. However, bone marrow transplant is never the first therapy. It is the cure, but it's not first, and we generally don't use it anymore. CML is a routine miracle where we use imatinib to stop the disorder. It may not cure it, but it controls it in most everybody. A 54-year-old man with shortness of breath, blurry vision, confusion, priapism. Its white cell count is extremely high, 224,000. 225,000. Wow. Remember, normal white cell count is under 10,000, 4 to 10,000. Now, this is predominantly neutrophils with a small number of blasts. What's the next step in the management of this patient? Well, this person's symptomatic. They're short of breath. They have blurry vision. They're confused. The initial therapy for controlling the white count is leukapheresis. What this is a person who has sludging from white cells. This, in a way, looks like polycythemia vera because that also is sludging. There's sludging from extremely high white cells over 100,000. It's extraordinarily rare to have this under a white count of 100,000. It's almost impossible in CLL because lymphocytes are very small. So it happens when acute myelogenous leukemia because blasts are big, and CML when the count goes up very high. Now, BCR-ABL is the most accurate, and bone marrow biopsy can be used sometimes. Transplant is done as a cure. Consulting people is never the right answer on step 2. But leukostasis reaction is an emergency, a hematologic emergency, and it is important to remove excessive white cells in the blood, then establish a specific diagnosis later. No matter what the etiology, take the white cells off. With a plasmapheresis machine, you simply put it in a centrifuge and you can convert it to taking off the white cells. So it's like plasmapheresis. Matter of fact, you can use the same machine, but you take off white cells, so it becomes the leukapheresis. Hydroxyurea does help and will help lower the cell count, but not as rapidly as the leukapheresis. Myelodysplastic syndrome, or MDS, is a pre-leukemic disorder. It's extremely uncommon under the age of 60. It presents with pancytopenia despite the fact that the bone marrow is working overtime. The cells are made a lot. There's a hypercellular bone marrow, but they get destroyed easily. The cells are defective. They break. It's like buying TVs that just don't work. They make a lot of them, and they're broken right away. Now, most never develop AML. A small number can, and it is pre-leukemic, but most never make it there. Well, that's not unusual in terms of pre-leukemic syndromes. I mean, most people with cervical dysplasia don't develop cervical cancer. Infection and bleeding is the answer to which of the following is the most common cause of death in myelodysplastic syndrome. There is a very important genetic defect called a 5q deletion. This is the most characteristic abnormality of MDS, and patients with 5q actually have a better prognosis than those who do without it. And that's because there's more to block. But MDS, older person, hypercellular, some go on to AML, most bleed and die of infection before they get there. Because the CBC is such a common test, MDS can present as an asymptomatic pancytopenia on a CBC in an older person done for some other reason. When symptoms occur, the symptoms are, I feel tired because I'm anemic and weight loss. I have infection because my white cells don't work like normal. And I bleed because the platelets can be low in number and low in function. And sometimes there's a big spleen, extramedullary hematopoiesis. There is no single pathognomonic finding in the history or physical. There's no single presentation that says, oh, that's MDS. It's pancytopenia, macrocytosis, normal B12 and folate level in an older person. Let's summarize those findings again. The CBC shows anemia. There's a macrocytosis. Well, there's a stressed marrow, so there's nucleated red cells. Remember, nucleated red cells go out early. They're like cells that should have waited in the marrow till they became reticulocytes, but they leave early because the marrow is stressed. There's a small number of blasts. The marrow is hypercellular. And there's ring sideroblasts. Ring sideroblasts is iron built up inside the red cell in the mitochondria. The severity of disease is based on, well, do you have 1%, 5%, 10% blasts? Now, there is a characteristic cell, a bilobed nucleated cell, bilobed nucleus. It's not a band. It's not a band. A band is not two lobes. And this is the Pelger-Hewitt cell. And this is distinct. This is the single most distinct lab abnormality in myelodysplastic syndrome, the Pelger-Hewitt cell. But there's much more of a presentation as a whole, saying older person, pancytopenia, but a high MCV. Yeah, you know what? The B12 and folate level is low. If there's a Prussian blue showing ring sideroblasts, or there's a few number of blasts, that will help you establish the diagnosis. The best initial therapy is to transfuse those blood products as needed. You give red cells most of the time. We don't transfuse white cells because they don't work. We use erythropoietin, although 80% of the people don't respond, but you try it and see who does respond. Lenalidomide, especially for those with a 5q deletion. Lenalidomide, which is a derivative of thalidomide, a TNF inhibitor. Lenalidomide decreases the need for transfusions. Very important. Azacitidine is another chemotherapeutic agent that decreases transfusion dependence, but unfortunately it doesn't increase survival. It's hard to find a drug that increases survival in myelodysplastic syndrome, and lenalidomide is a fantastic, terrific thing because it's melphalan substitute in myeloma. So it's in myeloma as a melphalan substitute sometimes. It is for myelofibrosis, and it's for myelodysplasia. That's a lot of myelo. Myelofibrosis, myelodysplasia, multiple myeloma, lenalidomide. CLL is a clonal proliferation of normal, mature B cells that function abnormally. This is a disease of older persons. 90% of people are over the age of 50. Most are asymptomatic at presentation. Now, when they are symptomatic, they present with fatigue. They're tired. They can present with big swollen lymph nodes or a big spleen or big liver or infection because you see those lymphocytes don't make normal immunoglobulins. Infections come into the body and the lymphocytes are supposed to process it and make antibodies against those infections. Pneumococcus comes into the body and says, oh, pneumococcus is here to kill you, but doesn't make the required amount of immunoglobulins. Now, as a biggie, there is no unique physical finding. And a small number, the Richter phenomenon, means that it converts CLL into lymphoma. 5% of CLL patients will spontaneously convert into lymphoma because lymphoma is a solid CLL, and CLL is kind of a liquidy lymphoma. CLL, the white count is usually above 20,000. And almost all of this is lymphocytes, 80 to 98, 99% lymphocytes. Half of them are hypogammaglobulинemic. That means they just don't make gamma globulins. The cells are there, but they don't function. They don't work. It's like having a TV that doesn't turn on. Anemia and thrombocytopenia occur because the abnormal cells can, instead of making antibodies against infections, are making autoantibodies against the other red cells or against platelets. And occurs from bone marrow infiltration as well. Now, if you have anemia on the basis of bone marrow infiltration, it's very bad. That's stage 3 CLL. That is a 1 to 2 year survival. If your anemia is on the basis of an autoantibody, you could fix that with steroids. That's like an IgG warm antibody. Now, this smudge cell you see here, this squished cell, is a lab artifact that happens in CLL. A cover slip crushes the nucleus and it squishes it or smudges it. Now, it is not a normal cell. It basically says CLL cells are more fragile. They break and they form smudge cells. If you have early stage disease, stage 0, just a high white count, or stage 1, big lymph nodes, no treatments needed, because these patients have a survival between 10 and 12 years. However, if you have advanced stage disease, these patients have to be treated. They get fludarabine and rituximab, in much the same way as think of it like non-Hodgkin's lymphoma. Now, advanced stage disease, a big liver and spleen or anemia or thrombocytopenia, this is the anemia and thrombocytopenia not from autoimmune disease, not from a circulating IgG, but from people whose bone marrow has been infiltrated with lymphomatous cells. It's a person whose bone marrow has been infiltrated with leukemic cells. These are people whose bone marrows have been crowded out with CLL. That is advanced stage disease and needs fludarabine, or if the choices list fludarabine and rituximab, then this is the best initial therapy for advanced stage 2, 3, and 4 disease. Remember, any patient who's symptomatic with severe fatigue and painful nodes must be treated. The most common wrong answer is mistaking advanced disease and thinking it's early disease and saying no treatment. The most common wrong answer is they present an old guy, 75, 80-year-old man with advanced stage disease, and because he's older, students say no treatment. Not correct. If it's advanced stage disease with anemia, thrombocytopenia, big splenia, or if they're symptomatic, they must be treated. In addition, don't forget, CLL acts a bit like HIV. The lymphocytes don't work, and they need pneumocystis prophylaxis in the same way you would for a person with HIV. Refractory cases that are not getting better with fludarabine need cyclophosphamide. In other words, if you have a person who's been getting fludarabine or fludarabine and rituximab and they're not getting better, you need to try something that may have more toxicity but also more efficacy. Try and get it under control. Now, mild cases with just a high lymphocyte count can still be treated with chlorambucil, which is rather cosmetic. It just brings down cell counts. Now, remember that if you have infections, those CLL cells don't make immunoglobulins. You have to lend them some immunoglobulins to help fight their infections. Autoimmune thrombocytopenia or hemolysis gets treated with prednisone the same as anybody else who's got autoimmune thrombocytopenia or hemolysis. The CLL cells might make no immunoglobulin. Lend them some with IVIG. Abnormal immunoglobulin that attacks its own white cells and also its own platelets or its own red cells, prednisone. Hairy cell leukemia is an unusual disorder. Look for middle-aged people who have pancytopenia, big splenia, monocytopenia, very low number of monocytes, and an inaspirable dry tap, despite there being a hypercellular marrow. But remember, there's no reticulin fibers. That's how you know it's not a person with myelofibrosis. No reticulin fibers, okay? And there's also no teardrops. Teardrops and reticulin fibers are part of myelofibrosis. And the hairy cells have filamentous projections on the cells, or hairy cells. Now remember, that filament projection is not reticulin fibers on a marrow. This is off the white cell itself. The most accurate test is we use the CD11 or tartrate-resistant acid phosphatase. Tartrate-resistant acid phosphatase and TRAP has been used. And the treatment is cladribine. Cladribine is specific for hairy cell leukemia.